Thank you. Right, hello, and hello to those online as well. Thank you for having me here today. As Sue said, I work at the Royal College of Midwives. I'm also a practicing midwife at a NHS trust in the east of England. And I'm here today to share the RCM's Maternity Disadvantage Assessment Tool, so also known as MatDat for short. I've got some cards that I can pass around, and there's a QR code on the back so that you can access the tool online afterwards. This was created in collaboration with Lambeth Early Action Partnership, using National Lottery funds as well. I just wanted to note before, in the presentation, we use the term woman throughout, as the majority of service users identify as such, but the RCM does recognise that some service users use non-binary identification, and this might be in fact a reason whereby additional support is required due to barriers to care, so that is referenced specifically within the tool. So let me have a look and see if I can get this working. Yes. Many of you, I'm sure, are well aware of the context for assessing social need in pregnancy, and this moves on quite nicely from Alice's talk, because a lot of what I'm talking about is how we assess social need and specific personalised care plans within our community setting usually, because that's where the majority of that antenatal care is happening and where we're having our booking appointments. So I'll talk a bit around, first of all, the context of why MatDat was initiated, and then also I'll show you some of the practical aspects of the tool. And also the key role that we play as midwives in ensuring that the appropriate support and referrals during pregnancy are available to women and their families. And the reason for this is we know that poor maternal and neonatal outcomes are really strongly associated with a wide range of social complexities, such as whether they're known to social services already, non-English speaking women, those living in deprived areas, those from minoritized ethnic groups, anyone who's had delays in accessing antenatal care, where they're living in households where domestic abuse is perpetrated, for example. And we know we've got lots of statistics on this and on multiple disadvantage. The Social Exclusion Task Force concluded that there's evidence of a clear relationship between the number of parent-based disadvantages and the range of adverse outcomes for children. We also know that we can, if we have the opportunity for early intervention, if we can identify those specific needs and make early referrals and give that family appropriate support, then we can reduce those health inequalities. So, for example, these are some of our latest Embrace data, and 2 women living in the most deprived areas of the UK are 2 times higher chance of dying. We know that at least 9% of those women who died had multiple disadvantages. And this was an older report that just really brilliantly brought together that concept of how multiple disadvantage can impact families. And that's that constellation of biases that was seen with the women whose cases were reviewed and who died. And we continue to see that in stillbirth and neonatal death rates. So where stillbirth rate is significantly higher for the most deprived, for women who live in the most deprived areas of the country, that trend has continued. And this is one of the most worrying statistics, is that widening gap, the disparity in neonatal death rates between those who live in the poorest areas of the country and those who live in the wealthiest areas. And again, we see this as a result of the impact of systemic racism within healthcare and society and the health inequalities this creates, where we continue to have black women twice as likely to have a stillbirth. And there was, in fact, a 10% increase in stillbirth rates for Asian women, and similar for neonatal death rates, although actually finally seeing some small improvements in this area. So you might have noticed there's a significant shift in terminology in some of these earlier slides. And when I refer back to older studies and reports, we talk about vulnerable women, but actually what is much more useful is to describe the person's situation or experience. If we use language such as vulnerable women, it can be reductive and depersonalising. So in the context of moving away from this depersonalising label, how do we assess social complexity and multiple disadvantage in a way that we can all understand? Oh, sorry, went too quick. So how we currently measure social complexity and multiple disadvantage, essentially it doesn't really exist in a universal way for midwives. So following Every Child Matters, there was a big national drive that helped social care, health visiting and primary care. So health visitors have an assessment of social needs at their first visit, and they have these levels of universal, targeted and specialist care, and that's for children up to 5 years. GPs and social services, children's centres have a safeguarding 4-tier system, which if any of you work in safeguarding might feel more familiar, because obviously midwives who are specialised in safeguarding will be using some of those thresholds. But these tools, unless they're adapted locally, they're not appropriate for maternity services, as they cover issues related to much older children and weren't designed by midwives. So they're not a tool that we can really connect with and use to help understand women's needs at booking. So it leaves us without that tool. And while midwives can make social services or mental health referrals for women in serious need, it's recognised that we don't have a consistent way to assess and plan for lower levels of care or wider social need. And without this, women and birthing people are less likely to receive appropriate preventative support during pregnancy. A shared language also has the potential to help us to articulate multiple complexities. And services most often use proxies to measure the needs of their cohorts, such as ethnicity, age, index of multiple deprivation. But this actually doesn't take into account what our real caseload might feel like. And therefore we can end up being under-resourced and our workload under-measured. So before I go on to describe the development and utilisation of the MatDat tool, or MatDat, the T is for tool, I find that really tricky. I wanted to just give some context of the Royal College of Midwives campaign around this, because this can't exist in isolation, and a lot of what we're calling for ties in with what we've just been discussing, in fact. It's important that we appreciate the ideal circumstances in which MatDat can be effective and can thrive and can be best utilised. So our position statement for supporting midwives to address the needs of women experiencing severe and multiple disadvantage calls on all UK NHS bodies to adopt our 5-point plan, which is outlined here. So midwives need autonomy and flexibility when caring for women experiencing severe and multiple disadvantage. So we need to be able to manage our own caseloads, basically, and have the time to do that. We need to be given additional support to navigate services for women who are experiencing severe and multiple disadvantage. So we need clear referral pathways and opportunities from effective multi-agency working. That means not redeploying your specialist midwives so they can't go to those multi-agency meetings. So it means that we protect that workload and recognise the risk that exists there. We need to be appropriately trained to support women experiencing severe and multiple disadvantage. And we also need to be supported and empowered to work in partnership and with the same women where possible. So that's where continuity is so important. Because we need to see them on that journey, and we need to be able to recognise when they haven't been able to disclose issues at that first contact. We need to be there for that trusting relationship to continue to develop. I feel like I'm preaching to the converted, but... and then we need that the health and safety and well-being of midwives is protected when caring for women with experiencing severe and multiple disadvantage. And this is about clinical supervision, opportunity for reflection, and debriefs, and the essential time that it takes for all these things. It's one thing to say, oh yeah, you can access clinical supervision, but we actually need time built into our working days to enable that. So that last statement is available on the RCM's website if anyone needs to access it. So in spring 2024, after I believe this is pre my time at the RCM, after a few years of work, we launched the MatDat, and this was following an extensive consultation with NHS maternity services, safeguarding and mental health leads, service users and wider stakeholders. And we did do a little update in January 2025 to bring in a bit more around parent-infant bonding as well. So that's the link for the tool, but as I said, I'll pass around the QR codes. Again, it is available on the RCM website, and it's available publicly. There's also, we worked with LEAP, as I said, and the evaluation that they did, so their original tool was called the MatDat, so Multiple Vulnerabilities Assessment Tool, and they did undertake an evaluation of this at the time. And this goes back to looking at what the problem was, much like what I've already described, midwives having to rely on a gut feeling around assessment, because you can there's things not quite working, but how do you articulate that and escalate that and get the right support in place? We have existing informal systems on IT, electronic records, for example, such as yellow flags, but they don't actually distinguish the differences between the levels of need. We have trouble articulating our concerns to others. Sometimes if you know someone well, but you can't quantify it to someone else, it's really difficult to escalate. We often miss those lower levels of need. And this is what came out in the evaluation, not me just saying it. The system relies heavily on safeguarding midwives as a safety net to uphold thresholds for internal triage. And there's also caution around safeguarding and inappropriate escalation. So sometimes we don't necessarily say that is something that does need escalating, because we've got nothing to refer back to. And a lack of clear pathways for women who have socially complex lives, who don't reach thresholds for safeguarding or mental health referrals. How can we support them? So the work evolved into the MatDat, and that responded also at the time to an Embrace call to develop a UK-wide specification for identifying and recording the number and nature of social risk factors, updated throughout to offer appropriate enhanced support and referral. And so in developing the MatDat through this consultation, we've hopefully met that call. But it's a work in progress, I have to say. So our end product, the MatDat, is a standardised tool, and it's to support midwives in holistically assessing the social complexity that women might face during their pregnancy and afterwards. It's based on women's broad social needs, and it guides midwives to identify a level of need, a level of care, you might say, between 1 and 4, which I'll come on to describe. It assists with making personalised care and support plans, and it supports multidisciplinary communication. And it helps also for services to plan resource allocation. Because as I said before, if you could say in your caseload, well, I've got 3 women at a level 4, 5 women at a level 3, 10 women at a level 2, and the rest of my caseload is 0, then you can start to compare caseloads and actually allocate resources, aka midwives, as we've just heard, more appropriately. We also at the time produced the position statement I mentioned, and an iLearn module. So if you remember, you can access that iLearn module, and also within MatDat there's a planning guide for care. So the levels of care work similarly to those used by social care and health visiting services, because we need to complement what they're doing. But so for example, level 2 is enhanced support, and that might mean referral for home start support, use of baby banks, an early health assessment, or referral to talking therapies. Or there might be family trauma, and a more personalised care plan is needed around appointments and hospital-based care. Then we've got level 3, and this is where you might be meeting a threshold for section 17, so child in need, and level 4 where you might be meeting a section 47 for child protection needs. But doesn't necessarily, for level 3, it doesn't necessarily mean that everything within level 3 would require referrals to social care. There's multiple factors that can exist, and sometimes that might also prompt you to say, well, actually, there's so many complexities. They might all sit at level 2, but actually all of those together mean really she should be under level 3 care. And this is something that we know that if there's early identification of need, particularly at levels 2 and 3, then the original evaluation found that women might actually be less likely to escalate to level 4. So how do we assess this need? So the tool has 3 domains across which you would look at a woman's care and situation and needs. So you've got what are called the woman's developmental needs, so whether that might be physical or mental health. A lot of this is history you're gathering anyway, so it's just pulling together all the threads of what you're learning through a booking appointment and through antenatal contacts. She might have issues around social interactions and finances, Or you might have concerns around parent-infant bonding and wider partner relationship. So, for example, it might be that someone's got severe hyperemesis. Do we ever really think about whether they need more support if they've got more children at home, if it's impacting their mental health? She might have hyperemesis throughout her pregnancy, but we wouldn't be able to articulate that as a level of need. So it would enable you to say, well, actually, perhaps that's a level 2 threshold, and we should be putting a lot more support around her. Other things that you consider in domain 1 are things like tocophobia, substance misuse, self-esteem issues, sleep problems, and wider social interactions. Then domain 2 is around environmental factors, so thinking about what her home situation is, where she lives. So it includes security and safety of their physical and social environment, but also exposure to discrimination. This is where you're going to pick up things like level of poverty, risk of homelessness, exposure to crime within the household and wider community. And then domain 3 is around parental and family factors. So this includes common safeguarding issues, as well as family relationships and even reproductive health. So was the pregnancy wanted? Are there